Yes, sir.
Hello.
Yeah, yeah.
Now we can hear the voice.
Prathmesh sir, Dr. Rahul, Dr. Vikram Sharma sir are with us in the relay room
Perfect.
and they are ready to talk with you. Over to Dr. Vikram, Dr. Rahul.
So, so as far as the patient is concerned, he is a 43-year-old male patient with a history of RTA. And if you see the sagittal sections, you can see the sections. Can you see the MRI images?
Yes, quite good.
And you can see that there is a tear in the ACL and a part of the stump is visible with what we are talking in the morning, and it is torn from the femoral side. So this may be a grade 1 or grade 2 sort of an ACL femoral sided avulsion, the Sherman grade. And what we are planning here is we will be planning to do an ACL reconstruction probably, and we will try to repair the stump if it is possible. So that is the second part. If it is possible, the stump is good, we might try to repair that stump. That is number one. Rest everything looks okay. The meniscus on the lateral side looks fine. The meniscus on the medial side looks okay. We'll have a look on the intra-op view or probably on the under surface. There may be some tear. If there is a tear, we can address that as well. And if you see on the coronal images, we can appreciate that there is a bone edema which is a sequelae of an acute injury which is seen on the lateral tibial plateau here. Okay, so rest of all is fine, and if you can see the notch, you can see the signs of the ACL ligament injury here in the notch. So I think that is it, and we'll start with the, I'm just going to scrub and now we'll be starting for the live surgery per se. Any questions so far?
Do we have any kind of weight bearing X-ray?
I think a regular X-ray is there.
Weight bearing X-ray is available or even stenogram is also available.
X-ray beta, X-ray, X-ray.
Prathmesh, you can go on doing the scrub.
Yes, yes.
Meantime, we'll examine the X-ray and once you are back, then we can
अपना इको बटन फ्लेक्स और स्क्रू और नीचे पीक बटन, हाँ बिल्कुल स्टैंडर्ड वाला. सो है, हाँ एक्सेल लगा लो. माइक पे लगा,
हाँ, गाउन पे लगा देंगे. भैया
वो मुझे लगता है अरे 5 mm का,
हाँ एक्स्ट्रा
वाइट कलर का 5 mm का, हाँ ठीक है, वो भी श्योर. बटन बटन फ्लेक्सिबल ब्रीज कर दो. अब की बार आदमी विदाउट प्रेस पे देगा नहीं, विद प्रेस. पिछली बार हमने बोला देने वाले में विदाउट प्रेस. मुझे दिखा दो ना, यहाँ पे पड़ा 15 मैं देख लेता हूँ.
यस सर. यस सर. हेलो. ओके ओके. एक्सरे पे फोकस करें. ओनली एक्सरे. यस सर, जस्ट अ मिनट सर, वी आर डूइंग. जस्ट अ मिनट सर, माइक इज हियर.
और स्कैनोग्राम हो तो स्कैनोग्राम भी दे देना. विद ब्रेस हो तो अच्छा है. फ्लेक्स विद ब्रेस है. So now if you can see here, the X-ray is pretty normal. You can see a minimal increase in the tibial slope, maybe around 8 to 10 degrees, but I'm okay with that. So as far as the X-ray goes, it is almost a normal looking X-ray for me. No change in plan with the X-ray as such. Okay, can we start on the live surgery, please? Marker, please. Marker. Tuning and fit.
Can you please demonstrate any clinical signs of ACL insufficiency?
On the examination or on the X-ray?
On examination.
On examination, yes, clinical examination, yes. So, infected?
What kind of attachment you had applied on the implant too?
So this is which में क्या end? So this is our setup. There is a nice OT setup here, and a very nice arrangement by Guru Kripa Hospital, Sikar. And we will be just demonstrating the arthroscopy and the subsequent findings, and we'll be doing the ACL reconstruction probably with stump repair. So this is my standard setup. If you can see, it's a supine position. There is a leg holder on the ground, and the advantage of this leg holder is we can actually adjust the position what we want, and we can keep it in any particular flexion as we desire. So in ACL reconstruction, we might need to do surgery at different flexion angles. So we can adjust the flexion angle completely, and there is no need of any other assistant. The knee is pretty stable. Is it clear?
Yes, sir.
Okay. So now as far as the skin markings are concerned, as I told you, we press the inferior pole of the patella. So when we press the inferior pole of the patella, you will see two bulges, one on the lateral side and one on the medial side. And the tip of the bulge, you will make a lateral portal on the lateral side, and a little bigger portal which is sort of an oblique incision like this on the middle side, and this single incision or a single portal will suffice both the medial portal and the low anterior medial portal. Okay, so these are the two anterior portals for me. The lateral portal, which is little higher, is a smaller portal. The medial portal is little bigger, and this is the more oblique sort of an incision to accommodate two portals. So instead of two portals on the middle side, I will just place a one bigger portal. Now this is the tibial tuberosity, and my tibial insertion or a tibial incision will be approximately an inch below the tibial tuberosity and in an oblique fashion, because the nerves are usually running in this direction, and we don't want to cut the nerve so as to cause a medial hypoesthesia. So it will be more of an oblique medial incision here, just about an inch below the medial tuberosity. Incision. So to cut. So now needle, please. Tuning and fitted. Yes. So now I'll just So now this is the view that I want to see. Meniscus on the top, and okay. So this is my medial portal, just a little bit more high, nice. So little bleeding, maybe a little bit of sign of an acute injury. Okay. So now if you see here, this is my anterior cruciate ligament, and what you can appreciate here is lot of blood vessels in this side. Can you appreciate that? And this sort of a blood vessel is a sign of an acute injury, and this is also a sign of a good healing potential, because the vascularity is here, and therefore the blood healing or the healing of the ACL will be from distal to proximal in the direction of these blood vessels. So this is what is called as a biological healing or biological consideration while doing an ACL reconstruction surgery. So I'll just make a portal which is little bigger, as I told you, about 1.5 to 2 centimeter portal on the middle aspect, and then I'll just use my shaver to just drain away the hematoma a little bit. Okay. And this is my anterior half of the anterior horn of the meniscus. This is the ACL that we are talking about. Shiva, please. Suction on. So we'll just clean the little bit of debris. Stop. So now this is the ligament, and the ligament is torn like this, and this fragment, if you can appreciate, is been avulsed like this. Okay. So this is sort of a between Sherman 1 and Sherman 2, as we were discussing in the morning, but this part is probably not repairable. So I'll just shave away this only part, which is a loose flap. Here you should be very careful because you are trying to do a remnant preservation, and if you have anything which is loose, you can just shave off that part, and you should try to preserve the most of the part of the ACL which is intact, and then we can just remove a little bit part on this side of the ACL. Okay. So we will preserve this part of the ACL which is intact, and probably just remove a little bit part on the middle side. Okay, just removing a little bit more on the. Okay, so now this is the remnant which is intact. This part of the ACL is avulsed from the femoral side. So if you go on this side, you will see that the femoral footprint is absolutely exposed. This is a relatively acute case. The resident ridge is seen right here. I'll just show you a bit more clearly. So a little bit of shaving is needed, so I'll just do it clearly. Stop. Okay. So now this is the part of the ACL stump which will probably try to preserve. This is the resident ridge right there, and this is the area of the footprint which has been torn. I'll just pardon me for a little bleeding view. I'll just clear the hematoma, and then it will be more clear for you, more clearly appreciated. Need RF, please. So we are just cleaning the remnant, and right now the area which we are clearing is basically the area of the resident ridge. Now at this point of time, I'll just remove this portion of the ACL remnant. Okay. Stop. So now on the lateral side, what you can appreciate is the anterior horn of the lateral meniscus here, the posterior horn of the lateral meniscus here, the stump which is there here. RF, please. Stop. Okay. So now I'll just ask my assistant to do a lateral opening for me, just as to visualize the lateral meniscus properly. We'll just have a diagnostic view, as I told you. ब्लीडिंग बहुत है. शेवर वो कितना है सर? टूनी के कितना है? ब्लीडिंग ज़्यादा है. Look. Show चलो. Stop. Just make it straight once. Just make it straight. So just clear the bleeding once. Okay. So now just make it a little bit lateral traction. Just slow. So now you can appreciate that there is a tear in the lateral meniscus. Can you see that? So occasionally this is a message that occasionally you may have a good looking MRI osteostitch. So you may have a good looking MRI, but then there is always a chance of having a tear on the medial aspect of the knee and the lateral aspect of the knee. So meniscus tears are many a times underreported on the MRI. So here you can see that there is a tear on the inner surface or the inferior surface of the lateral meniscus. Can you appreciate that? Although this is a stable pattern of tear, but I would still like to fix it with one of the anchors. Now Osteocare has come up with a very nice all inside repair device that is called as an osteo stitch. The top part that you see on the here is basically the popliteal tendon that you can see up right there, and this part of the lateral meniscus, there is an under surface tear, okay, and when you just elevate it, there is a gutter which is called as a popliteal gutter, and the popliteal tendon will be just seen posterior to that. So, okay. So this is the area of the lateral meniscus which has got an under surface tear. Okay. So I would like in this particular kind of case to repair the under surface of the meniscus with a all inside device. As I told you on the lateral aspect, I would be more happier using an all inside device. On the medial side, we have multiple options. We can use inside out device in the posterior horn. So this is basically the posterior horn of the lateral meniscus. Okay. Now luckily this device, if you can see, is called as an osteo stitch device. This is an all inside device. This is developed by Osteocare. It is a peak based device, and it is one of the device which has got the smallest delivery needle. So if you can see this needle, the needle diameter is very small, that is 1.5 millimeters. The anchor size, the peak anchor size is very small, that is about 1 millimeter diameter. So it's, yes, please. So it becomes a very very good anchor in such such type of cases for a very good repair. Take it out. Okay. So right now what we can appreciate is that there is a tear right there. Okay. Take it in. Take it out. So this is my first bite. The first bite goes onto the capsular side like this. Okay. Then you just take the first click. The second click, it will fire it on the posterior part of the capsule. Okay. And then I'll just pass the second bite. The second bite will be almost onto the top part like this. Okay, so that is okay. Take it out, take it in, and then you can just take it back. Okay. And once you just tension it, you will appreciate that this lateral meniscus is repaired nicely. Okay. Pro, please. So this is the inferior part of this lateral meniscus or the inferior surface, and this has been repaired by the osteo stitch meniscus repair device by Osteocare. Can you see that? Okay. So this was the tear, and we have repaired it nicely with the use of a single anchor, because this is a stable pattern. You don't need to use much more anchors. A single anchor is usually sufficient in this pattern, and if you tighten it, the gap is usually closed, and there is the suction test will become negative. Okay.
So there is a question that whenever you find a meniscal tear, do you divide the edges with the meniscal?
So this is an acute case. Usually, if in a chronic case, you should do it, but this is an acute scenario. You get seen a lot of bleeding there. So lot of bleeding was there, lot of healing thing was there, and this is a stable pattern. So in this case, I didn't debride. But yes, if there is a chronic sort of a tear, it's recommended that you debride it nicely so that to make it conducive to healing. So this is how the repair looks like. Finally, the suction test became negative. If you can appreciate the initial suction test, it was positive, And here you can appreciate that the suction test has become negative. The tear which was seen in the initially is not seen now. It's very stable pattern. If it has been a sort of a chronic tear, I could have placed one or two more anchors. But since it's an acute injury, we are doing an ACL reconstruction also. So we'll be just calling it a day as far as the meniscus part is concerned. Now this is the medial side. If I go down like this, was what Dr. Rahul was describing in the morning. Here is the area of the ramp lesion. So this is something similar to what is called as a Gilchrist view. And we can see the posterior horn of the medial meniscus here, which is usually good. Probe please. And if you can see here, it looks good. So even if we just lift it up on this side, this looks good. If it looks on this side, this is looking good. So as far as the meniscus part is concerned, on the medial side, there is probably no tear. It looks pristine. Okay.
Yes.
So
there is no right to sign also on the middle.
Yes, and if you see here, this is the area which we will watch for the ramp lesion. Luckily, there is no significant ramp lesion also here. So this is similar to what is called as a Gilchrist portal, which we usually make to see for the ramp lesion. And if you want to see the posterior medial portal, you can make a needle here, make a portal here in the posterior medial aspect and see this area of the ramp, which is, if it is not possible here. So it is good here. So I'll just finish my work here, and I'll just harvest my graft and then proceed for the ACL reconstruction. Knife, please. So now if you appreciate that this is a tibial tuberosity, we make an incision which is approximately an inch down to the tibial tuberosity. Forceps please. Cameraman, can you please focus on this area? Lights please. Now many people were asking about the approach and the exposure of the hamstring tendon here. Okay. So now there is one important thing I want to show you. Can you see this small leash of vessel here? The small vessel you can see there, right there. Can you appreciate that? This one. Can you appreciate at the tip of my knife?
Yeah.
So this is what is called as a leash of vessel, and this is usually a sign of the location of my semitendinous tendon. So if I just cut my fascia at the level of this leash of vessel, I will be probably right on to my semitendinous tendon. Okay, and just this you can see, then when I am cutting it, you can see it more prominently. Can you see the leash of vessel now?
Yes, sir.
Okay, so now this leash of vessel is even more prominently visible in this direction. Okay. So now you can see this is what we call as a leash of vessel, and it is nothing but it is a nutrient artery of the semitendinous tendon. Can you appreciate that?
Yes.
Now this will usually help us to identify and harvest the semitendinous tendon. So we go in at the level of leash of vessel, we take a loop underneath it and just pull it, and this is how we and now at this point of time you can appreciate that there are multiple bands here, and these bands need to be cut for your tendon to be secured and be mobile. We want to take it out a long length because we are using a single tendon, as we also already discussed in morning by Dr. Vikram sir. So try to take maximum length of it like this. Okay, and then you take your needle. So many people were asking about the use of ethibond or fiber wire. So this osteocare provides us with a 4x1 set of wire, which is UHMWPE. Can you show the cover? So this is a set of 4 fiber wires, number 2 in size, very strong, non-braided, so no risk of any infection. And I usually prepare the first end of my tendon on the patient itself, so that my assistant has to do a little bit less work and there is less chance of the graft getting loose and pulled away into the thigh. So this is my first passage in preparation of the tendon, like this, and then I'll just take it off from the insertion. Okay. Now at this point of time you need to check the excursion, you need to pull it like this. Still I am not happy because my excursion is not complete. I have cut one down, but my excursion is not what I expected. It is not coming properly. So that means there is still 1 or 2 bands which are remaining inside, and we have to feel it and cut it properly. Can you feel the noise of cutting? So now if you can appreciate, we have a much more इसको निकाल देना. So now it's okay. So this much of excursion we want. You can see that it is coming almost an inch more than its insertion. So this much of excursion minimal we want. Grasper please. Okay, okay. And this is a very good length hamstring that we are able to harvest. Okay?
Yes.
Any questions till now, so we can proceed further? 20 flex. बेटा कपड़ा डाल देना, कपड़ा डाल देना नीचे. टोकार प्लीज. RF please. So now again we are just exposing the area. Shaver please. So the most difficult. Yes, sure please.
There's a question from the audience. Dr. Mendra wants to ask that while you were preparing the lateral meniscus for repair,
yes,
you are repairing it, how do you isolate popliteus that it doesn't come between the suture?
Okay, so when we are using an all suture anchor like this, you need not to bother, and even if you fix the popliteus with the all suture anchor, it will not matter much. So you are fine if you are fixing the one of the buttons into the popliteal tendon, that is okay. That will make your structure less mobile, but usually there will be no difference in your healing rates and things like that. So I am particularly fine with it. I will not put it into the popliteal tendon, but somehow if it goes into the popliteal tendon, I am totally okay with that. RF please. Okay. So now what I will do is, I will just do a little bit of preparation here. RF please. RF please. RF please. RF please. So this is the area which is anterior to the resident ridge. I will just clean it up more for the visualization. Stop. RF please. Stop. Okay, so what we have done so far is we have prepared the upper part, removed the tissue on the upper part, and removed the tissue on the lower part. Okay, and now I'll just retract the ACL stump with my shaver, and the structure that you see here is your resident ridge, and the structure which is seen posterior to that is your stump on the femur, and we are debriding a part of the stump. So as we have predicted, this is a classical type 2 Sherman lesion which has some of the tissue attached on the femoral insertion of the ACL. Stop. So now you can appreciate that we are retracting the ACL with our shaver. The anterior part, this is our resident ridge. This is sort of the bifurcate ridge that we have seen, and we have removed the stump, or we have removed it, the insertions of the femoral footprint here. Okay. So by and large, this is the repair that we are going to perform. So this is basically my ACL stump which is seen there. RF please. So there is about 20% of the stump which was on the femur. RF. RF. So this is I am marking my femoral insertion. Stop. That is okay. And this is my tibial insertion. RF please. Stop. So I would plan to put my tibial tunnel here. RF please. Stop. Okay. RF please. Still. So the thing we are discussing in the morning is the tibial insertion is basically a duck's paw or a V-shaped insertion, and the insertion is here in this portion. And what we can do is, RF please, we can clear the interior part of it without damaging the outer layers. So this is stop. So this is the area where we want to put our tunnel for the tibia now. Okay. So this is the area where we want to put our tunnel on the tibia. We'll just retract our ACL like this. Okay. So we'll just retract the ACL like this so as to appreciate the tunnel on the tibial side, and we'll just retract my ACL like this so as to expose my femoral sided footprint. Now a common problem which may happen and which is sometimes unavoidable is of damage of this stump because of the reaming from the drill. That is usually, that can happen, but usually I don't worry about it, because even if it is torn, I can remove it in the end. So that is usually not a problem. So now this is my femoral footprint is almost prepared. Stop. Stop. Pointer and then एक pointer चाहिए, pointer. Hitesh pointer. Okay, so what I do is now I'll just retract it a little bit. Okay. Now I ask my assistant to flex the knee up to 90 degrees. As I told you in the morning, the best visualization will be on 90 degrees. Okay, just bend it 90 degrees, not more than that. We don't need a hyperflexion in this step, that is okay. And I'll just ask my assistant to retract it a little bit. Okay, so this is my posterior part, and this is my resident ridge, and probably somewhere around here. Maro? No. So probably somewhere around here I would like to place my insertion of the Maro. Stop. So probably in this area we would like to place our femoral insertion. I'll just be confirming it once more. Okay, RF please. Clearing a part of the lateral condyle. Stop. Shiva please.
Prathmesh sir, your arthroscopic view is not very good.
Just a minute.
Will you do some adjustment with the zooming of the camera?
Yes, just a minute, we'll do it. Just a minute, we'll do it. यहीं से है. Is it better right now? Little bit?
Yeah.
So it's okay, I think. Stop. Okay. Okay, so something like this. Okay. Offset guide, please. So now you have two options. You can use a flexible reamer as I told you in the morning, or if you don't have a flexible reamer, you can just use your standard rigid reamer and just do it in a little bit of more flexion. So I put it in, let's see, 90 degrees of flexion. I put it on the posterior wall like this, okay, and then I'll ask my assistant to flex the knee. Okay. very good, very good, very good. So we are right over the footprint that we have almost demarcated, and here we are almost there. Drill please. So you can see almost we are good. Go ahead, go ahead.
So while engaging your breath pin, you are keeping your knee around
100, 120, 110 or 120. Okay, can you see that?
During engaging of the breath.
Initially less, then you can increase it. Yes, go ahead, go ahead. नीचे हाथ नीचे रखना, हाथ नीचे रख, हाथ नीचे रख, हाथ नीचे रख. Go, 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 go. So it's a marked breath pin. Go ahead, go ahead, go ahead, go ahead, go ahead, go ahead, go ahead. आपको ना कैमरा इधर लेना पड़ेगा. Go ahead, 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 go ahead. Very good. So that is okay. निकाल दो, है ना? Reapply, 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 reapply it, reapply it, reapply it. So we are just adjusting the outside camera. Just a minute. Yes, sir. Hilna nahi. We are just adjusting the outside camera in order to see the retro gauge. Retro RF chalao. RF. Stop. Shiva, please. Can you see the view, outside view now?
Yeah, it's good.
Okay. So you can see that our breath pin is in the posterior condyle at a good distance. Go ahead. Just no, knife देना बेटा. यहाँ पकड़ो, इसको पकड़ो सर. Knife please.
Prathmesh sir, can we see the medial surface of the lateral femoral condyle in relation to your breath pin?
Just a minute.
Where is your
Yes. We'll show you that in a minute. So we make a small hole on the lateral aspect. I'll just use the this retro gauge once, and then I'll show you that. Just go ahead. Go ahead. Go ahead. So can you see the R mark? Go ahead. Okay, go ahead. Can you see the R mark? Slight rotate, Hitesh. Slight rotate. Can you see the R mark? So this is the marking for the retro gauge. And this is a retro gauge. We are very well versed with this sort of devices in the trauma practice. Can you see that?
Yeah.
And then we put it from this side. Okay? And we'll put it right to the edge of the lateral femoral condyle. Okay? And you can see that the length is 40. Can you appreciate this length? 40?
Yeah.
40? So the tunnel length is 40. So at the first step, we have just drilled our breath pin, but we are know with very surety that the length of the femoral tunnel is 40 millimeters. So we have not committed to the tunnel. Still we know the exact length of our breath pin at the first step itself. Okay?
Yeah.
And now you have two options. You can drill either 4 mm first and then 9 mm after that. 9 mm. You can drill 4 mm prior and 9 mm after that, or you can do vice versa. You can do 9 mm first and 4 mm later on, doesn't matter. Here we are using the Eco Button Flex, which is an adjustable, micro adjustable device. It is in between, it's a hybrid loop. It is in between the fixed loop and the adjustable loop. So it has features of both fixed loop as well as the adjustable loop. Drill please. 9 mm. Okay, we'll just take it. So I'll just show you. So this is basically a device which has got properties of both fixed loop as well as the standard loop. So now you make your calculations as per your 20 mm fixed loop, fixed continuous loop. Okay. So 40 mm is your tunnel length. and so you 40 mm is your length of the tunnel. So you should make a socket which is ideally at least about 13 less. So 27 mm, 27 millimeter of socket will be recommended. Okay. So just go ahead, please. Go ahead, fast. Yeah.
So you are going to create a socket of 27 millimeter length.
Yes.
20 millimeter for your graft and 7 millimeter that
To flipping, yeah. Go ahead, go ahead.
Is it so?
Yes, yes. Go ahead. Stop. Go ahead. Stop. Sure, please. So now your surgery is basically on the 20 mm fixed loop pattern. Okay. Stop. So we have 15 now. Stop. Go ahead. Go ahead. Go ahead. Go ahead. Stop. Uh, 5 more millimeters. 5 more millimeters. Okay, so we are fine. Okay. Artery, please. Artery, please. So we have drilled up to 28 millimeters. So that is good. And then just take it out. Bus, take it out slowly. Yeah. Take it out, that's it. Okay. So okay. So we are good here. Okay. Drill, please. Passing wire, please. Now you can see here that is around 28 here as well. Okay. So the step of the antegrade depth measurement is not required at present. Go ahead. Now I can start feeling my cortex now. Okay, and go ahead. That's it. Take it out. Take it out. And now I'll just pass my wire through that. Okay, take it out from this side. Okay, and then I'll just make a loop on this side and finish it up. So this is my femoral tunnel which is drilled. Okay. Now I am coming to my tibial side. Now as we have discussed, we have tried to preserve as much of the remnant as possible here, and we'll retract the remnant like this with a shaver, and we'll try to put our tibial tunnel right here in this space. Okay. This much of the remnant we are trying to preserve as much as we can.
So in your every case, either you are doing preservation of the remnant or doing the chronic ACL reconstruction.
Yes.
As your footprint will remain same, or some variation.
We can, if you don't have a stump, then you can do a little bit of variation. You can make your tunnel more medially. But here, because the stump is intact, we can see the blood vessels also going here very nicely. Can you see the small blood vessels
so
here?
In this case, you are just medial to the lateral tibial ligament.
Almost there. We are almost there. So this is my lateral meniscus, and we are making our tunnel, tibial tunnel right over there. Okay, go ahead.
A bit lateral.
Yeah. Go. Stop. लंबा करना पड़ेगा. लंबा करो. Go ahead. Okay, so there is fine. थोड़ा उधर गया है. निकाल दो उसको. Disengage. So I am little off on that side probably. निकल गया ना. So if you can appreciate my it is right here. Can you see that? RT please. RF please. हाँ नहीं चलेगा. 4 mm remote serial trimming 4 mm पहले. RF चलाओ. RF चलाओ. 4 mm, 6 mm and 8, 9 mm. Stop. RF chalao. Stop. So we are good there. Okay, can you see my wire there? Okay, it's absolutely anatomical. It is almost through the footprint. Now I'll do the serial reaming so as to preserve my remnant. Okay, 4 mm first. Go ahead. 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 Enough. Enough. Take it out. Take it out. So this is my first reaming, that is 4. वापस देना. Then I'll drill with my 6.
Dr. Prathmesh, there is a question.
Yes.
Here you are going through the footprint.
Yes.
When you don't have a footprint, do you
Okay.
follow any kind of bony landmark or an anatomical landmark?
Yes. So my anatomical landmass is again this this femoral lateral meniscus.
Just
Go ahead.
end up with anterior arm or
Yes. Go ahead. Go ahead. That's enough. Take it out. वापस नहीं, वापस वायर दे दे. वायर दे दे. Give me the wire. दूसरा वायर दे दे. Now give me the 9 size wire. चक लगा. Artery, please. थोड़ा सा बाहर लेना उसको, स्लाइड बाहर लेना, बाहर अंदर बाहर लेके अंदर डाल. हाँ. एक ही मिनट रुक, एक ही मिनट रुक. थोड़ा बाहर लेना हल्का ना. टेक इट आउट, टेक इट आउट, टेक इट आउट. अंदर जा, अंदर डाल, अंदर डाल, अंदर डाल, अंदर डाल, अंदर डाल, अंदर डाल, अंदर डाल. ब्यूटीफुल. हाँ, गो अहेड. हाँ. Go ahead, go ahead. Very good. Take it out slowly, slowly, slowly. Take it out. We are good now. Good now. So you can see. So you have a little struggle here because you want to preserve your remnant. If you don't want to preserve a remnant, it will be a non-struggle surgery. But again, as I told you, a little bit of preservation of remnant is good. Stop. So now you can see that this much of the fragment we are able to achieve safely. Hook please, stop. Okay, so we are good here. Retractor please. Yes.
Dr. Vikram this side.
Yes, sir.
Some of the surgeons, including Pancha, they recommend that split this remnant in between with the help of a scalpel or something like that.
Yes, so you can do that, but this is a better technique because here we are reflecting whole of the ACL. We don't want to cut it, but we are reflecting it, so we are able to see it better. Artery. Give me an artery. So now.
Dr. Prathmesh, can I see this tunnel or posterior?
No, it's absolutely anatomical. I'll show you. It is absolutely anatomical. It's not posterior. Take it out. Take it out. Take it out. Relax. Take it out. Take it out. Use. That's beautiful. So this is how we just take it off. Pani please. Pani. Share. दूसरा पानी कनेक्ट कर दो प्लीज. So the anatomical aspect of the ACL is not affected because your anatomical ACL is anyway going to be preserved. The stump is going to be preserved. So you can see that whole of this stump is now intact. Okay. Okay, this whole of the stump is intact and we are passing the graft posterior to the stump. Can you see that? Graft please.
So for preserving ACL reconstruction, you go for the substance or you do like that?
In most of the cases where there is an intact some part of the graft which is remaining, we usually try to preserve the stump like this. If the stump is not there in a chronic case, then you can just remove the stump and do your standard way. That is not an issue. Pull. हाँ पुल लेंथ ज़्यादा है, मोटा ज़्यादा है. 9 में इजी था, 9 में इजी था, छोड़ दो. 9 में टाइट होगा, 9 में टाइट होगा बेटा, इजी करना था ना. हाँ पीछे पुल करो, पुल इट, काउंटर देना, काउंटर. Relax. So Shiva please. Shiva please, relax. No worries. Okay, so this is my button. This is the eco button flex that I was demonstrating. Just pull it a little bit slowly. Slowly pull. Pull it slowly. Counter. So now you can see, so this button has some advantages. One, it has micro adjustability, that is number 1. It has tape which is incorporated into the button, that is number 2. Okay, and the button itself is basically adjustable little bit. So what you can do is, you can just keep it. Pull it little bit more. Counter then अच्छे से. Okay, just no worries. Okay, pull it little bit more. Yes, so now you can see that we are able to flip the button on the outside. Okay. Okay, so we have flipped the button, but I will show you the intra-articular views. I can show you the button from outside. So right now what we can see is the ACL which is there. The tape is incorporated into the button itself. So that will serve as an extra thing. The remnant is totally preserved. You can see the remnant is preserved completely. It covers the graft completely like this. Okay, this is the graft which is anatomical, and the remnant which is covering the ACL thoroughly. Okay, and now what I will do is I will show you the outside view. So what I can do is I can show you the button from the lateral gutter. Shiva please. Shiva please. So this is on the medial side of the patella. This is the superolateral portal, and you can see the button there. Stop. You can show the flip of the button to the audience, please. Okay, and now you can take out the white and the blue sutures because the button is flipped. So you can use this technique for an adjustable loop also to confirm where this is pull the blue one. Okay, so now the button is free. We have pulled out both the buttons. Then I'll just pull the ACL graft here. There are some specific things that I want to show you. Number 1 is you can see the brace which is going through the loop itself. Okay, so here the brace is through the button itself. It gives an extra fixation because sometimes you pass the loop, the brace through the loop, and then it occasionally will not give you that much of fixation. Counter please. Hold this one. Now I will show you the micro adjustability feature. Okay, so this is basically the eco button flex loop. Now I will cinch the loop. So when I am cinching the loop, the graft will go in. So 20 mm button, 40 mm tunnel. Now now at present it is 20 mm of the graft into the tunnel. Okay. Now this 20 mm button is cinched, and this will reduce to about 17, 16 or 15 millimeters as tolerated depending on the length of the tunnel. Now when my assistant is cinching the, you can see that there is a shortening of the loop which you experience here. I can show you that on the inside picture also. Yes. This is a unique patented mechanism if you see here. So as compared to any other adjustable loop, this is a micro adjustable feature. So the cinching is only about 5 millimeters maximum. Okay. So there is a loop here, and this loop is done seesaw, and this is a patented mechanism. So when you seesaw this button, this small V becomes a large V. Okay. Can you see that? And you push on this side. So you keep the ACL tensioned, and you can see that there is a shortening of the loop here. Okay. This shortening is much less as compared to any adjustable loop. So the chances of loosening is also less as compared to any other adjustable loop. So because we are doing only 3 or 4 millimeters of micro adjustability. Okay. Just do that please once more. Okay. Can you see that? Okay. So this is a unique patented mechanism which is able to reduce the size of the loop from 20 millimeters to about 16 or 17 millimeters in this particular case. Okay. And this will lead to graft which is going much more into the femoral tunnel per se. So almost I will not say complete, but it will be more than your fixed loop, and it will be less than your adjustable loop, but it will be, as I told you, this is a hybrid mechanism. So it has got both the features of fixed loop, advantages of fixed loop as well as advantages of adjustable loop. Now you can see here that there is a peak button which is there. Can you see that?
Yes, yes.
So this is again a new product designed by Osteocare. Can you see that? So you can use this instead of a suture disc. It's a peak material, very strong in size. 4 buttons, 4 holes into this, and you can tie the brace and you can tie the sutures from the graft separately in this particular peak button. Okay?
You won't be going to the partial fixation.
I will be doing both. Okay, so wire please. 10 mm suture please. 10 mm please. 10 mm suture. 10 mm screw, suture, X-fix anchor. Okay.
Do you consider superior fixation during war?
RF please. RF please. RF.
Do you consider R superior? Blue. Like doing double fixation?
Yes, I am more happy doing double fixation on the tibia. RF please. Chalo, wire please. RF please. Stop. So now this is the remnant, and you can see the remnant is totally covering my ACL like this. You cannot even make out where I put my graft. Okay. And if I flip it like this, you can see the graft nicely. Okay. So this is sort of like we do our retraction in our trauma cases. It's just retracting it and putting the ACL into its place. Now I'll just put my screw as an aperture fixation. So this is again a Osteocare new design peak screw. You can see here. Can you see? It's a peak material, bio-inert material. Okay. And this.
Do you have graft at the aperture? Is it protruding graft or this is recess inside?
So you put it in the aperture, because tibial sided will be fixed with the, because the tibial side will be additionally fixed with the peak suture disc as well.
Can you show us the graft at the tibial level when we are putting the screw?
There is no graft there because the graft is in.
Graft is recessed.
Graft is into the aperture actually. I will show you from the scope inside. Just a minute. So I have got a very good fixation here. Okay, so this is done. If you can just appreciate, okay, take it off. If you can just appreciate, my graft is well fixed here, and I can go in from this direction, and this is my screw. Okay, and this is my tunnel. These are my suture threads. Okay. So this is my peak screw from Osteocare. Again, a new design, gives a very good fit. Okay, you can see the markings of the screw here in the cancellous bone. Okay. X-fix anchor, please. Knee scorpion, cannula. Okay, so now. So usually I would keep it as in as possible, about approximately 1 centimeter it should go in, because the normal size of the tunnel is around 45 millimeters. If you can see it on the footprint, that is okay. If you are not able to see on the femoral footprint, that is also okay. So now I will be just doing the procedure of my stump repair. That is, I use an X-fix anchor from Osteocare. So this anchor is a very unique anchor, and we had developed this anchor basically for the use of the centralization. So whenever we are doing a root repair and you want to do a centralization, we had developed this anchor, and lately we found out that this is somehow a very good anchor. Flexion a little bit. Lately we found out that this is a very good anchor for the stump repair as well, and the ACL primary repair. Thoda kam flexion, slight kam flexion. So you can see that my tunnel is right there. I need to put my anchor approximately at this position. Go ahead, counter please. Take it out. It is anterior, almost on the resident ridge, little anterior to the femoral tunnel. We don't want it to go into the femoral tunnel. Seesaw kar dena. Take it out. Take it out. So the unique part of this particular anchor is, which you don't get in any MNC, is its size and its thread dimensions. So it is the lowest profile anchor which is available. Seesaw please. It's the lowest profile of anchor which is available. The size of anchor is smallest, and the thread diameter is also the smallest. You don't have anything available like this in any of the multinational companies. This is a number 0 fiber wire, you can see. And this has an advantage, because if you put a standard, any of the standard MNC anchors, you have a very big thread, and this thread can cut through these delicate tissues of the ACL. Okay. So now what I'll do, I'll just flip my portals. एक आदमी को पकड़ना होगा यहाँ से बेटा, होल्ड करना पड़ेगा. So I am flipping my portal. I have made this on the, इसको पकड़ के रखना ऐसे. Knife please, knife please. Retriever knee scorpion, knife, retriever knee scorpion. So I'll just extend my lateral portal a little bit. I'll put my cannula.
No training required, you just step in and come out.
This is a basically drill in anchor. This is a drill in anchor, just like your any Bankart anchor basically. All suture Bankart anchor, but the all suture Bankart anchor has got more dimensions. It is a thicker anchor with thicker sutures. This is a thinner anchor with thinner sutures. Take it out, take the cannula out, just relax. So I'll take one of my suture limbs now. A knee scorpion. Now I'll use my knee scorpion device to pass the sutures through the ACL stump.
It is going to be a mattress suture or a simple?
In this particular case, I will take a simple suture. In this particular case, it depends on case to case, but in this particular case, you don't need to take a mattress suture. So you can appreciate here that this is almost closing up very nicely in this direction. Artery please, cannula please. Artery please. Within retriever please. Cannula पकड़ के रखना. Hold it. Hold this one. Stable पकड़ के रखना. So I have passed the white one. Now this suture is very. Most of you must be using the knee scorpion. And you must be knowing that knee scorpion cannot be used with a number 2 suture. You can use either a 2-0 or a 0 number fiber wire with a knee scorpion. So let's say if I use any other anchor, I will not be able to take the bites through the scorpion. So this anchor being a smaller diameter anchor, smaller size of my suture, I can take direct bites from my knee scorpion per se. So this knee scorpion can take the direct bites from the stump without you don't have to shuttle it. Green retriever ready. Green retriever. So now you can see here two things. 2 of the sutures are through the anchor and 2 of the sutures are through the tissue. Okay. So now I'll just be taking my simple suture right there. Okay, this and this, and I'll pull it like this. Okay, isko pakdo. Okay, and then I would tie the knot just like any of your shoulder knots. Okay, so this is basically borrowed from the shoulder phenomenon. Okay, so this is my, if you can see, and you take the thread which is passed through the ACL as your post and then repair it onto the stump. Okay. वो देना बेटा, क्या नाम है तेरा? ग्रीन रिट्रीवर देना. गिव मी ग्रीन रिट्रीवर. आर्टरी देना मुझे. गिव मी आर्टरी. गिव मी आर्टरी. गिव मी ग्रीन रिट्रीवर. So I just like to tension it a little bit onto my femur side because I want to get a. इसको पकड़ो. कटर रेडी रखना. One here. Cutting piece. Hold this one and this one. Cut it. RF ready रखना. Okay. Green retriever. So we have used the first, you have tied the first one and now I will be tying the second one. Okay. पकड़ना सूर. So again I will take the same bite just like the principles of my shoulder scopy, like a rotator cuff tear repair. That is okay. So this is why how we do it. Cutter दे देते, कट देते. So this is the final picture, and you can appreciate that this is actually closing very nicely here. Okay, the stump is very closing nicely, and this is my graph. This is my graph.
Zoom out, please, Dr. Prathmesh.
Yes.
Zoom out, please.
Yes. Okay. 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 And now I'll be just closing my case with the fixation of the peak button on the tibial side. Okay. Take it out. Okay. Okay. Now this is what I am telling you, that this is basically a button, a peak button, which can be used here. Now here you have two options. So we are good here. So you can see that this is my button, and this is the two braces wire which have gone into the button. Okay.
So Prathmesh sir, in every case in your practice scenario, are you using the internal brace?
Most of the cases, yeah.
But in body your talk you explained that.
That was a repair case. That was a little different case than this one. That was a repair case. But एक वो देना soft tissue आ रहा है बीच में. एक artery देना. Give me artery. Artery. इसको पकड़ना. इन दोनों को पकड़ना. So इसको छोड़ दो. छोड़ दो. So this is the button which is almost sitting very perfectly now. This is a peak button. This sits much better than your suture disc. ऊपर उठा इसको. AC नहीं चल रहा क्या? And when you tie the internal brace, usually it should be tied at more extension. So typically this will be tied in a more extension kind.
that is differential tightening?
Yes.
You will tight your ACL graft in vertical 30-degree flexion and
Yes.
Your brace in to extension.
Yes.
Is it so?
Yes.
Prathmesh sir, you
Yes.
had placed the interference screw inside the tunnel.
Yes, that is a very common question that is asked.
The knee position you made the reference.
Yeah, it will. You are right on that. But what we have seen is it does not make much difference. Knife.